Welcome back to Chapter 28, Part 2 of the reproductive system. So just as we did for the males, for females, we will also begin by talking about the anatomy where female gametes, oocytes, are generated and follow the direction of movement toward the uterus. For females, the ovaries are the gonads that produce oocytes, which refers to the still immature stage of female gametes. Ovaries also secrete hormones such as estrogen and progesterone, along with inhibin as a negative feedback of FSH. Now, the ovaries are not technically connected to the fallopian tube or the uterus, so they have to rely on multiple connective tissue to support its position in the body. For example, the mesovarium, which is this main area here, is what support and stabilizes the position of each ovary using the ovarian hilum. The other two ligaments you can see here, the ovarian ligament and the suspensory ligament. And mesovarium is this part right there. That's the mesovarium. Here is where you have ovarian ligament, which connects the uterus to the medial side of the ovaries, whereas the suspensory ligament connects the lateral side of the ovary to the pelvic wall. So your ovary should be nice and stable in place, even though is not physically attached to the uterus or the fallopian tube. So interior tissues of the ovaries, just like any glands we were talking about in terms of the kidney, adrenal glands, the outer portion of the ovary right here is called the cortex, and the deeper region of the ovary in the middle is called the medulla. Now, the uterine tube actually has three different names. Okay, you have the uterine tube or the fallopian tube or the oviduct. Okay, so the uterine tube goes from here all the way to the rest of this. There's this whole thing, which this actually attaches directly to the uterus. And it's also lined with ciliated columnar epithelium. Okay, remember that, for sperm has flagella to help it propels itself and swim up the journey up into the female reproductive system. But for females, oocytes don't have flagella, nor do they have other things that help it swim. The egg doesn't know how to swim. Okay, so that's why the fallopian tube, which is mainly to deliver the oocyte from the ovary to the uterus, has to rely on the cilia within the oviduct to move itself along. So if you imagine the fallopian tube like this, they're lined by many cilia on there, and there's the oocytes moving along within the oviduct, and the cilia would go, kind of do what's a sweeping motion back and forth, okay, in one direction, it moves in one direction to sweep the egg along, so then the egg will move forward toward the uterus. Okay. So the uterine tube is actually divided into three sections. The first section is where the ovulated oocyte will first arrive at, is called the infundibulum, okay, which is this first portion of the oviducts. Okay, so this portion right there is the infundibulum. It has an expandable funnel with this finger-like projections. It actually kind of looks like a little flower that sits close to the ovary, and that flower-like part of infundibulum is called the fimbriae, and it kind of sits hovering over the ovaries like this. Okay, so it's like a little flower, okay, that hovers over the ovaries, so that when an egg ovulates and bursts out of the ovary, the fimbriae's finger-like projection would just sweep that egg into the oviduct and lead the oviduct into the uterus. Okay, so I will show a very good video in a bit about showing this whole movement of the fimbriae that sweeps the egg into the oviducts. Now, the second part after the infundibulum is called the ampulla, okay? And that's why I said it's good to remember the name ampulla. At least it means some expanded region. So this portion right here is still pretty big, coming out from the fimbriae. So that's the ampulla region. And the last region is called the isthmus, okay? Which is this whole part of the oviduct. That isthmus part is what connects the oviduct to the uterine wall. Okay, now fertilization has to happen between the ampulla and the isthmus. Okay, so it has to happen somewhere within here in this spot in order for the embryo to have enough time to travel down the oviduct and mature enough for implantation in the correct spot. Okay, what happens is after fertilization of a sperm on an oocyte is that the ovum will then become a zygote, okay, and it will become 2-cell, 4-cell, 8-cell, etc. until you get a ball of cell. And by the time you get to close to the uterus right here, it should be close to what's called the morula stage. And at morula stage, it will then become a blastocyst, and that's when then the embryo will implant into the side wall of the endometrium in the uterus, okay? So in order for that embryo to have time to mature before it implants into the wall, you have to have enough distance for that embryo to grow correctly. Okay, so that's why usually optimally you want the fertilization to happen somewhere around there. Okay, and within the uterine tube, there are epithelial cells. Or within the epithelium, there are cells called PEG cells, and they actually secrete a fluid that will complete capacitation of sperm and also supply nutrients to the sperm and the preembryo, because technically what's moving around within the oviduct is either sperm or the egg that has been fertilized by a sperm, the preembryo. Okay, and all of those stuff also need nutrients. So that is why those PEG cells there are providing any necessary nutrients to those other to those things in the oviduct. Okay. All right. So now, going back to the ampulla and the fimbriae, the reason why, people can have what's called ectopic pregnancy is because the fimbriae is not physically attached to the ovaries, okay? Which means they're not connecting in any way by ligaments or connective tissue, okay? So if somehow the ovary ovulated an egg, and that egg, instead of traveling into the oviduct by the fimbriae brushing it inside, that egg somehow went outwards into the abdominal area somewhere around here instead, then technically speaking, that oocyte still has the possibility of being fertilized by a sperm, because sperm will travel from the vagina through the cervix into the uterus up either of the fallopian tube. And remember, there's that big opening between fimbriae and ovaries, which means sperm can also travel out into the abdominal area, reach that oocyte, and still fertilize that egg. And hence, you will start to have an embryo forming within the abdominal area. And that's one type of ectopic pregnancy. The other type of ectopic pregnancy has to do with the cilia. If cilia was not functioning correctly within the oviduct, and I said that the oocyte has no ability to move on its own. So if the cilia is not functioning correctly, the oocyte will be stuck in the oviduct, okay? And if it was fertilized by the sperm, okay, that oocyte will start turning into a zygote, into an embryo within the oviduct, okay? And it will be stuck there because the cilia doesn't push it along. And ultimately, as the embryo gets bigger and bigger, okay, it can actually cause the fallopian tube to rupture, okay? And that is actually a very dangerous situation for the mother. And a lot of times with ectopic pregnancy, it's super, super painful, and it has to be, removed almost immediately. I mean, there's no other way to save the embryo, unfortunately. And, pregnancy would have to be terminated in ectopic pregnancy's case. But, that's all for the to save the life of the mom, okay? And the thing is, you know, with ectopic pregnancy, you know, usually it gives you a lot of pain. So for females, if you are ever, you know, have severe pain out of the ordinary on one side of the abdominal pelvic area, okay, please take note of that in case that is something like that has happened, okay? But I'm talking about out of the ordinary because some people will still have very severe menstrual pain or ovulation pain on one side of the body, but other than that, you know, just be careful when you have severe pain on one side of the abdominal pelvic area, okay? All right, so the oocyte or embryo, if fertilized, will then travel to the uterus correctly, which mainly functions to protect, nourish, or remove waste for the developing embryo and the fetus, okay? And of course, it will be in charge of the final delivery of the fetus when it is ready to be born into this world, okay? Just like the ovaries, the uterus is also suspended with multiple ligaments and connective tissue, okay? You know, not uterus, ovary, fallopian tube, oviduct. We want to keep all those suspending organs together and tethered together. So that's why you have these multiple ligaments we'll talk about. The biggest one is the broad ligament right here, which is basically a mesentery that encloses the ovary, the oviduct, okay, and the uterus itself, okay? Make sure all three parts of this female reproductive system stays together. And then you have three other ligament that is mainly in charge of holding the uterus in place, okay? So the uterosacral ligament is right here, okay, on the back here. And as an easy way to remember, uterosacral, okay? Sacral, which refers to your sacrum, which is at the back, okay, your backbone, okay, the inferior part of your backbone. And then you have utero, so it connects your uterus to the sacral bone, okay? So it keeps the uterus from moving inferiorly or anteriorly, okay? So imagine if your uterus tried to move this way, okay, due to a shock or whatever from the back, you have these ligaments that's going to pull the uterus backwards to make sure it doesn't move toward the front. Round ligaments are this one right here in the front, which connects the uterus to the anterior part of the body cavity. Okay, so this is the anterior part in front of the body. The body's in front side, and then the body's back side, posterior side. Okay. So it restricts the uterus from moving posteriorly. Okay, so if the uterus try to move this way, it's tethered by this big round ligament. So make sure that uterus doesn't move backwards. And then on the bottom inferior part of the uterus, you have what's called the cardinal ligaments, which is to prevent the uterus from moving downwards. Okay, towards the base of your pelvis, the lateral walls of your pelvis. Okay. Now, since the uterus is pretty well kept in place by these 4 different types of ligaments, and so technically speaking, which leads us to this bizarre myth that I've heard before, where after childbirth, if you were to squat, okay, they say that your uterus can you can risk having your uterus fall out of your bottom, okay? Technically speaking, that shouldn't happen because you have all these ligaments there to hold your uterus in place, unless those ligaments was really, really stretched out, or they were accidentally cut during surgery. Let's say it was a C-section or something, then that can happen. But, you know, if everything is normal, you know, your uterus is very well kept anchored in place by all these ligaments, okay? So that's why those are just weird myths out there. All right, so the uterus are divided into 4 different parts, okay? So these different parts are kind of, you know, pretty easy to remember. You have the body of the uterus, okay? The fundus of the uterus on top, which is this area right here. And that's why your stomach, if you remember the stomach like this, Okay, this was called the fundus, which means the top of the stomach. So that's why the fundus of the uterus means the same thing, the top of the uterus. And then you have isthmus, which is the more narrow part of the uterus right there, isthmus. So that's another good word to remember terminology-wise, because isthmus probably refers to somewhere where it's converging from an expanded area to a more narrow area. And then you have the cervix on the inferior, most bottom part of the uterus. Okay. Now, the uterine wall contains 3 layers, just like your heart. Remember your heart, you have your pericardium, myocardium, endocardium. Well, same thing for the muscles of and layers of your uterus. Okay, you have the perimetrium. So that's this out here, which is just a serous membrane that surrounds your uterus. And then you have your myometrium right here. Okay, that's the very thick muscular layer that's going to participate in labor and delivery, in helping the uterus to contract and expel the baby outside of the body. And then you have endometrium, which is this inner layer right here. Now, with that inner layer, it is actually divided into 2 layers. One's called the functional layer, one's called the basal layer. Okay, the basal layer is what attaches the functional layer of the endometrium to the the basal layer, is what attached the endometrium to the myometrium. Okay, so the basal layer of the endometrium is what attaches to the myometrium. The functional layer is what changes in thickness throughout menstrual cycle. Okay, I'll talk about the details of why our endometrium needs to get thickened and decrease back to thin layer in a bit when we get to the menstrual cycle. But the order of these layers, again, is perimetrium on the outside, which is a very thin layer. And then you have your myometrium. Okay, so that's perimetrium. Myometrium, the muscular layer, thick muscular layer. And then you have your basal layer. Okay, so that's the basal layer of the endometrium. And then you have a very thick layer of functional layer of the endometrium. Okay, and usually this is packed with spiral arteries that's gonna provide oxygen and blood within that area, and it changes in thickness throughout the menstrual cycle. All right. Okay, the vagina is what leads to the uterus around the cervix area. It is lined with stratified squamous epithelium because it's prone to abrasion, and it is non-keratinized. If you remember from 2401, when we talked about the integumentary system, we talked about keratinized versus non-keratinized cells. Keratinized are those that are like skin cells, or surface of our skin cells that are more waterproof. But for non-keratinized cells, they cannot they cannot stay dry. They have to be continuously moistened by mucus. Okay, so that's why within the vaginal canal, there will be cervical gland that continuously make secretion to lubricate and moisten that area. Now, around the opening of the vagina are masses of erectile tissue called bulb of vestibuli. Okay. Okay. So you have the vagina right here, the picture. And then in this area is a mass of erectile tissue called the bulb of vestibuli on both sides of the opening of the vagina. So the bulb of vestibuli actually share the same embryonic origin as the corpus spongiosum in males. If you remember, within their penile tissues, there was corpus spongiosum that surrounds the urethra, and corpus cavernosum that surrounds those big central arteries. Okay, so this bulb of vestibuli is the same embryonic origin as the corpus spongiosum in males. Why this we talk about this is because technically speaking, when the baby embryo is being formed in the mom's womb, okay, it will it knows to determine whether if it's a male or female. They will know to produce the male reproductive organs or the female reproductive organs. So there's that small little bulb in the beginning that will then diverge to either to become a penis versus part of the bulb or vestibule or the clitoris for the female. Okay. Now, around the opening of the vagina is pieces of tissues like this called the hymen. So these are elastic fold that partially blocks entrance to the vagina, and it will, technically speaking, will remain intact until impact. Okay, and this can be even physical impact, meaning if you accidentally sat on a pole or something that went between around in that groin area that really hurts the outside of your vagina area, it can actually still impact the hymen, okay, and it will still bleed. Okay, now inside the vaginal canal, technically speaking, there should be harmless bacteria within there, and their metabolic activity is what's going to create the acidic environment of the uterus. The uterus and the vagina is a very important place for a baby to be formed, and hence we cannot afford for it to become infected. And yet it has this big opening for bacteria to take hold and colonize. So that is why the interior of the female reproductive system tends to be more acidic than our normal pH. Okay, this is mainly to restrict growth of any pathogen within the interior of the reproductive system for females. Now, the external genitalia is very simple for a female since most of it is on the inside. The main area right here is called the vulva, okay? And the vulva is divided into a couple of different parts. You have this outer layer here that can contain hair. It's called labia majora, the bigger lip that surrounds the vestibule. This area right here is called the vestibule, and then you have this smaller lip right here. Oh, it's getting messy. Let me go ahead and erase some of that stuff. Okay. So you have labia majora, labia minora, and labia minora usually is hairless and smooth, okay? And this center area tissues right here are your vestibule, okay? Mons pubis is this layer on top of the vulva, and usually is a pad of fat tissue covering and protecting your pubic symphysis. Remember, the pubic symphysis is that cartilaginous joint that connects your two pelvic bones together. And then you have the clitoris, which is right here. Clitoris, again, like I said, it has the same embryonic origin as the penis for males. It contains erectile tissue. So those are called corpus cavernosum of the clitoris. Okay. The greater vestibular glands are located on the bottom here on both sides, or you can see it down here, and they are important for making secretion into the vestibule area to make sure this area right here is moistened and lubricated. Okay, the greater vestibular glands has the same embryonic origin as the bulbourethral glands. Now, for female sexual function, it's a lot simpler. There's no 3 E's. It's just arousal, which is mainly dominated by your parasympathetic stimulation, and that's going to cause an engorgement of the clitoris, just like how the parasympathetic stimulation was necessary for males' erectile function. Okay, it enlarges your blood vessels. Your blood vessels undergo vasodilation, more blood rushing into that area, and in a sense causing those erectile tissues to become engorged. Now, the breasts, of course, they lay in front of our chest. And remember, our chest muscle right here in this area is called pectoralis major muscle. And within our breasts, okay, for females, we have mammary glands. So each of these purple lobes right here is a bunch of mammary glands, and they're separated into their individual lobules. But all of them inside is mainly for lactation, which means making of milk, production of milk. And then you will see that there's these small white lines that leads to the mammary glands. Those are your lactiferous ducts that's going to collect milk from your mammary gland into the lactiferous sinus, which is these expanded region right there around the breast tissue. Okay. And lactiferous sinus will then deliver the milk towards the nipple, which then will have about 15 to 20 openings for ejecting milk to the baby. Okay. Now, resting mammary gland should be dominated just by ducts and mostly adipose tissue, whereas an active mammary gland is dominated by those tubulo-alveolar gland from milk. Okay, so this is how an active mammary gland histology would look like, whereas the resting mammary gland would kind of look like this. Looks very different, and you can see a lot of empty spaces where milk is stored within those areas, and hence that's why for some females, when they're in lactation, their breasts would increase in size because a lot of the mammary glands are actively making milk, making it larger around that area. But it doesn't happen for every female, and size has nothing to do with how much milk the mom produces. Okay. All right. So just like males that have prostate gland problems, females can also have a variety of problems associated with the reproductive system. So ovarian cancer, for example, is one of the third most common in females, but it is actually the most dangerous because it is very difficult to diagnose in early stages. It's always the best prognosis for any cancer patient if we can detect cancer at an early stage. Okay, but for cancers that does not have a marker where we can detect by blood, then usually we have to wait until that cancer is so big that it starts giving you secondary symptoms. That's when you realize something's wrong, go to the doctor, go for a checkup, and that cancer cell or tumor can be as large as maybe stage 3 or even stage 4, and it starts infiltrating into other organs of the body through metastasis. So that's why, ovarian cancer is most dangerous because it's hard to catch them at an early stage. Contrary to prostate cancer in males where they have that PSA that they can, detect in blood. For females, there's no marker we can detect in blood for ovarian cancer. Okay, the other most common type of cancer in females is cervical cancer. And this is why annually it is recommended that females do the procedure called pap smear. And pap smear is a form of exfoliative cytology where the doctor will open up the vaginal canal, okay, and they will put a swab in there, kind of scrape off some cells from the cervical area, okay, the cervix, and then they would actually do a biopsy with your cells, okay, and try to see and do a histology slide out of it and see whether they can detect any abnormal looking cells that looks like it's forming, like a tumor looking cell, okay. So that's why what pap smear is important for is in case there is cervical cancer forming within that area. Fibrocystic disease or cluster of cysts within the mammary gland if it becomes inflamed. And then breast cancer, of course, is the leading cause of death in women. By statistics, 1 in every 3 women will get breast cancer sometime in their life. And of course, breast cancer is where tumor starts to form within the mammary gland itself. Now, again, I don't think there's a blood marker for breast cancer, and a lot of times that's why during well woman exam, doctors go in there and feel your breast for abnormal lumps, and they also encourage females at a certain age to do it on their own every day when they go to shower or something. They can do a breast tests of their own where they make sure that they are feeling around the breast tissue area to ensure that they don't feel any abnormal hard lumps forming, okay? And usually the lumps are not painful. That's another key thing for detecting cancer cells is they're not painful. They're just this hard lump within tissues, okay? All right. And unfortunately, the survival rate of females through these type of cancers are a lot lower than males' survival rate from prostate cancer. Okay, prostate cancer survival rate are pretty high, whereas for females, a lot of times they may be able to battle through it once after removal of the tumor tissue, but if it already started metastasizing, then it's kind of too late. They go through chemotherapy once, then it comes back, the cancer, and they have to fight it multiple times. It's kind of a sad situation for these female reproductive cancers. The process of gametogenesis in females is called oogenesis, or meaning production of eggs. As I have mentioned, the timing for female oogenesis is very different from male spermatogenesis. Females begin making oocytes even before she is born, while she is still in her mother's womb. This is why some people say that a mother is technically not only carrying her daughter, but also carrying her potential grandchildren. Okay. Maturation of an egg cell usually accelerates at puberty, okay, because before puberty, all those cells is kind of halted at a certain stage within meiosis, as we we'll discuss, and then only once, or one egg or two eggs once a month, those eggs will mature and be ovulated and burst out of the ovaries, and then they will be of course moved into the oviduct and uterus for fertilization purposes. Okay. Now, the process will stop and end at menopause. In a sense, I tend to see menopause as nature's way of protecting the female's body. It's just childbirth overall is a rough process for the female's body to go through hours of labor and then expel the baby, and then also have all that blood to come along with it. Okay, older women also tends to have more complications. Not will happen, but it usually more likely to happen in older women. Okay. So sort of menopause is a way to save an older woman from having to go through all that rough process. So I always thought menopause is nature's way of protecting the female's body, even though it's pretty rough getting to the stage of menopause, because you've all heard of those premenopausal symptoms that people have to endure through. But from my standpoint, I would not want to go through labor and delivery in my 60s or 70s. So, I see menopause as a nature's way of protecting our bodies from having to go through that. All right. So again, the process of oogenesis starts with stem cells called oogonia, which divides via mitosis into your primary oocytes, and that is why your primary oocyte is still at diploid in this moment. And technically speaking, we are born with about 2 million of these primary oocytes inside our ovaries at birth, but they will degenerate to about 400,000 by puberty. Okay, and this degeneration process is called atresia in females, because we don't need all 2 million eggs. We only ovulate 1 or 2 each month. Okay, only if twins tend to run in the family, then you ovulate 2, or if you're close to menopause, that's when the body kind of tend to ovulate 2 or more eggs at the same time. But technically speaking, only 1 egg each month, and only from puberty toward the time you're in menopause. Okay, so you start puberty around 11 or 12, and then you may start menopause 45 to 55 years old. So that's about 30 years of worth of ovulation, which means we don't need all that eggs, and that's why they just go through degeneration into a smaller population size. Okay, and then your primary oocyte will turn into your secondary oocyte via meiosis 1. Okay, at this point, your secondary oocyte is a haploid. Okay, and What's strange about for females oogenesis is that they will produce what's called polar bodies. Okay, so you will see that in models in lab last week, you saw these 3 circle things coming out of the secondary oocyte. Those are polar bodies. We don't exactly know what their function is. It doesn't really do anything extra for the egg. It just comes out of the egg and starts to disintegrate. Okay, I hypothesize it as being, sort of like spermiogenesis is in spermatogenesis. Spermiogenesis is, sort of taking away all those unnecessary things before the spermatid become a mature sperm. So I kind of see that as a similar process for females, just to get rid of extra stuff within the oocyte that you no longer need via polar bodies, formation of these polar bodies. Now, what happens for female oogenesis is it will not complete until fertilization. Okay, it actually stops at metaphase 2. Okay, and it will be ovulated each month, okay, and only when it's fertilized by sperm, then the secondary oocyte will become a mature ovum, okay, and this marks the end of meiosis 2, okay. So technically speaking, we never finish meiosis 2. We are kind of stopped and halted at metaphase 2 when the oocyte is at secondary oocyte, okay. And then only when the egg itself is fertilized by a sperm, then we call that a conclusion of meiosis 2. Okay, so this is something very different from spermatogenesis, and make sure you don't confuse the two. Spermatogenesis, you do go from meiosis 1 all the way down to meiosis 2 until completion, and your spermatogonia has now become a spermatid, okay, and spermatid will then undergo spermiogenesis to become a mature sperm cell all in one setting. For females, you stop at secondary oocyte until ovulation. Every month, only a few of those will mature, okay, and be ovulated and get ready for fertilization. And only after fertilization does your secondary oocyte complete meiosis 2. Okay. So this is a good video that goes over very quickly about how the oogenesis process goes, okay?
The ovaries produce secondary oocytes, the female sex cells. During fetal development, stem cells, called oogonia, go through mitosis. Some of these cells develop into 46 chromosome primary oocytes. At the onset of female puberty, tens of thousands of primary oocytes each form part of a primordial follicle in the ovaries. Between menarche and menopause, each primordial follicle develops into a mature follicle, and its primary oocyte completes meiosis 1. Some primary oocytes become secondary oocytes, 23 chromosome cells that begin meiosis 2, then pause. Each month, one secondary oocyte is released into the uterine tube. Meiosis 2 is completed when the oocyte is fertilized. The resulting ovum can develop into a zygote.
Okay.
The ovary.
So, we will talk about the follicles described in the video that help with the maturation of an egg cell next, okay? So within the ovaries, there's what's called ovarian follicles. These are sites of oocyte growth and where meiosis 1 of oogenesis happens, okay? Now, what happens is you start with what's called primordial ovarian follicle, which houses just a single squamous layer of follicle cells that surround your primary oocyte within the egg nest. Okay, so last week, for your histology slide, you had to identify different stages of follicle within on the microscope slide, and these smaller circles you see around the ovaries that has just one single purple layer, very tiny, and you see some purple stuff in the middle. Those are primordial follicles that contain your primary oocytes. And then your primordial follicle will then become a primary ovarian follicle. This is where the follicle cells, now these follicular cells is for the enhancement and nurturing part of the egg. Okay, it helps the oocyte to mature. So that's why you have these follicle cells growing along with the egg. Okay. So primordial ovarian follicle will become a primary ovarian follicle when those follicular cells enlarge, divide, and you start to see multiple layers. So you see one layer around the oocyte and another layer around. Okay, so that's a primary ovarian follicle right there. And they would begin to produce estrogen for these follicular cells. Okay, zona pellucida is what will contain microvilli within that area to transfer nutrients from follicle cells to the oocyte itself. Okay, so because the follicular cells, like I said, is the nurturing part of the egg, so it is responsible for providing nutrients to the growing egg. Then the primary follicle, ovarian follicle, will become a secondary ovarian follicle, okay? And eventually it will get bigger and start to form what's called the tertiary ovarian follicle, which has two other names, either Graafian follicle or vesicular follicle. Now this is when follicular cells there's a lot of them around, and they also start to secrete a follicular fluid around this empty space area called the antrum. Okay, I'll talk about it in the next slide, but this is what expands the inner and outer layers of the follicle. And now what houses within the tertiary follicle right here is a secondary oocyte. Okay. Now, what happens with students is that they will easily mistake the secondary follicle with secondary oocyte. Okay, secondary follicle is this. Okay, where you have the primary oocyte still within it. There's about 2 layers or 3 couple layers of cells, follicular cells around it. Okay, it looks a little bigger. Tertiary follicle is the really big one, and for sure you'll be able to see this empty space area that I said is called the antrum. Okay, and it houses the secondary oocyte. Okay, because now the oocyte has matured enough from primary oocyte to secondary oocyte, and it's just getting ready for ovulation when it comes the time to do so. Okay. All right, so don't confuse between secondary oocyte and secondary follicle. Follicle cells is just for nurturing process of the egg, helping this egg mature along, okay? Whereas the oocyte is the egg itself, okay? Which is that purple dot right there, okay? All right, so let's see. There are 2 important cycles in the female reproductive system that coordinates ovulation and preparation of the uterus for potential fertilization and implantation of an embryo. We will begin by talking about the ovarian cycle for ovulation. It goes through a monthly process of maturation, ovulation, and degeneration of tertiary ovarian follicle during that 28 days. So with the 28 days, you can see why ovarian cycle and menstrual cycle kind of works hand in hand. They happen simultaneously and coordinate with each other to make sure that it prepares the female's body for housing an embryo, okay, if the egg was to be fertilized. So the first 14 days before ovulation is called the follicular phase, which is when the growing tertiary ovarian follicle will really rapidly increase in size. Only one of those will do that. Somehow when the secondary oocytes are growing, there's multiple of them that will continue to grow, but by the time follicular phase starts, okay, only one of those will start growing exponentially fast, while the rest of them will actually degenerate and stop, undergo atresia, okay? So that one that continues to grow exponentially in size, that's going to be the egg that's going to be ovulated that month, okay? This process is stimulated by FSH, okay? Remember, FSH stands for follicular, okay? So that's why follicle stimulating hormone, FSH, okay? So that's why FSH is in charge of stimulating the follicular phase of ovarian cycle. And I already mentioned the different parts of the tertiary follicle. So you have tertiary follicle, secondary oocyte. Okay, and it's all lined by different cells. This empty area is called the antrum, which contain fluids for transferring nutrients to the egg. There's also granulosa cells that lines the outside of the tertiary follicle, and then there's also corona radiata cells that surrounds the secondary oocytes. Now, just like how in males there's Leydig cells around the seminiferous tubules to make testosterone, females have thecoendocrine cells all around within the ovaries surrounding the tertiary follicle. Okay, and these thecoendocrine cells are in charge of making estrogen. Okay, so that's why it's analogous to Leydig cells in males. Then around day 14 is when ovulation happens, and a tertiary ovarian follicle will release a single secondary oocyte. Okay, the follicular wall of the tertiary follicle actually ruptures, break open, and release the egg along with the antrum fluid around it. And then the fimbriae will be attracted to the ovary and kind of hovers over the ovary area and allow the sweeping of the oocyte into the oviducts. After that, then you have the last phase, which is called the luteal phase. This is the latter half of the ovarian cycle during days 14 through 28. Okay, this is when a structure called corpus luteum is formed. Now, this corpus luteum is a very important structure because it makes the hormone progesterone, which is an essential hormone that maintains the thickness of the endometrial lining for embryo to implant into. Without corpus luteum, you have no progesterone, and what happens when there's no progesterone is that your endometrial lining, which is your functional layer of the endometrium, will be shed off, okay, and hence embryo can't implant properly. Okay, so that is why the corpus luteum is very critical for maintaining the lining of the endometrium for the embryo to implant and stay implanted instead of being shed away with menstrual fluid. Now, if there's no fertilization, however, the corpus luteum will degenerate about 12 days after ovulation. The egg actually has a very small window of survival. It has to be fertilized 12 to 24 hours after fertilization. But just in case, the corpus luteum only degenerate 12 days after fertilization, and they produce a pale scar tissue called corpus albicans. And because now the corpus luteum is no longer functioning, your progesterone and estrogen level will both decline, which leads to the start of your menstrual phase of the menstrual cycle. It actually stimulates the lining or spiral arteries within the endometrium lining to spasm, okay, and they will actually fall apart, and then all that blood will be shed away. I'll talk about that next in the menstrual cycle. All right, so the second cycle that works very well with ovarian cycle, and it must be coordinated together, okay, is called the uterine cycle, or more commonly known as the menstrual cycle for a lot of us, okay? It begins, like I said, at puberty around 11 to 12 years old and will continue until about 45 to 55 years old when menopause starts, okay? Again, it is also divided into 3 phases, just like the ovarian cycle. From day 1 to day 7, this is the first phase called the menstrual phase. Now, this is what happens when the oocyte is not fertilized and everything is removed to cleanse the uterus. So during this phase, the endometrial layer is actually degenerated and sheds off as blood and blood clots. What happens is that the spiral arteries within the endometrium layer will constrict. And when they constrict, the secretory glands underneath the endometrium layer will deteriorate because it no longer has a good supply of oxygen. The weakened artery then starts to rupture, and then blood will pour out into the connective tissue of the functional layer, and with muscular spasms of the uterus, it will be expelled out of the body. Okay, so this kind of illustrate by microscopically what happens during menstrual phase. This is the endobasal layer of the endometrium. These are those uterine glands I was talking about. Okay. Then the next phase around day 7 through 14 is called the proliferative phase, which is when epithelial cells of the uterine glands, which is all these here, start to spread and multiply across the entire functional layer of the endometrial surface, and it restores that thickness within the functional layer. This allows for their growth and also vascularization. Okay, what happens is within the functional layer of the uterus is of the endometrium is you have these spiral arteries that kind of spirals up from the basal layer all the way up to the top of the functional layer, and it is these spiral arteries that we're relying on giving oxygen to tissues around that area, to uterine glands around that area. And then if an embryo happens to be fertilized and come over here and starts implanting into the functional layer, these spiral arteries will be what's providing oxygen, nutrients for the baby as well. Now, proliferative phase occur about the same time as when tertiary follicles enlarge. Remember, when that tertiary follicle starts to enlarge during follicular phase, this is when your body is saying, we're about to ovulate an egg, you better prepare for potential implantation in case there was a fertilization. So that is why that phase is correlated with proliferative phase, to make sure that the endometrium is well prepared just in case that egg that's going to be ovulated soon will be fertilized. Now, the estrogen will actually stimulate and sustain the time of proliferative phase to get that endometrium as thick as possible. Then you hit the last phase, which is day 14 through 18, called the secretory phase. This is when the uterine glands will start to enlarge. Arteries are really long now that they cover the entire functional layer, functional layer of the uterus right here. And then, so the functional layer and all that artery will then spiral all the way up to the top. And all of this is actually stimulated by progesterone and estrogen that's released by the corpus luteum. And that's why I say corpus luteum is such an important structure within luteal phase of the ovarian cycle, because the maintenance of the corpus luteum is what's going to secrete progesterone, and progesterone is what's going to maintain the thickness of the functional layer of the endometrium for potential implantation of a baby. This activity will peak around 12 days of the secretory phase, and if it senses that there's no fertilization, no implantation of the embryo, then it's just going to return back to your menstrual phase. Spiral arteries constrict, you have spasm of the muscles, everything starts to rupture, blood pours out, and then everything is secreted along with the unfertilized egg out as menstrual fluid. Okay? And this is a very good video that goes through 2 cycles of what we just went through, the ovarian cycle and the menstrual cycle, and follow the development of the oocyte. It does a tremendous good job of showing how that fimbriae kind of glides over and hover over that ovary for sweeping that oocyte in when the secondary oocyte is burst from your ovaries. Okay, so make sure you go through this animation. It's very good. Very.
Ovulation is a part of the menstrual cycle when the ovary releases a ripe egg, or ovum. Inside the ovary are hundreds of thousands of follicles. Each follicle is a hollow ball of cells with an immature egg in the center. The typical 28-day menstrual cycle begins on the first day of menstrual bleeding. During the first 7 days of the cycle, a few follicles begin to grow at the same time. These maturing follicles secrete estrogen hormone into the bloodstream to prepare the lining of the uterus for pregnancy. Around day 7, all of the follicles stop growing and begin to degenerate, except for one. This dominant follicle continues to grow and nourishes the developing egg inside it. Around day 12, the follicle secretes a large amount of estrogen into the bloodstream. When the estrogen reaches the hypothalamus, and the pituitary gland in the brain, the anterior or front part of the pituitary gland releases a huge surge of luteinizing hormone into the bloodstream. Around day 14, luteinizing hormone causes the follicle to undergo a sudden growth spurt. Right before ovulation, the egg detaches from the inside of the follicle. The bulging follicle releases chemicals, causing one of the two fallopian tubes to move in closer and surround the follicle. The follicle swells until it bursts open, ejecting the egg and fluid from the follicle into the abdominal cavity. In response, the fimbriae, tiny projections at the end of the fallopian tube, sweep across the ovulation site and pick up the egg. Microscopic cilia on the fimbriae's surface transport the egg to the entrance of the fallopian tube. Inside the walls of the fallopian tube, muscular contractions gently push the egg towards the uterus. After ovulation, the egg lives for 12 to 24 hours, so it must be fertilized by a sperm from the male during this time for a woman to become pregnant. If it's not fertilized, the egg dissolves away and is shed along with the uterine lining during menstruation.
Okay. So hence, as the video went through with us, that these cycles, ovarian and uterine cycle, are highly regulated by hormones and must be coordinated in order for proper reproductive functions to proceed. Again, we start with the hormone that is produced by the hypothalamus, which is your gonadotropin releasing hormone, GnRH. Just as the male reproductive system, GnRH stimulates your pituitary gland to make FSH, and hence that's why it's called a follicle stimulating hormone, because it stimulates development of ovarian follicle, and your follicular phase of the ovarian cycle begins. That's why it was named follicle stimulating hormone. Now it also secretes inhibin to to stop FSH as a negative feedback mechanism back to FSH, and it also stimulates secretion of estrogen. Estrogen, as we have talked about from 2401, it stimulates bone and muscle growth, other than other stuff related to the reproductive system. Okay, it maintains secondary female characteristic, affect your central nervous system, which increases sexual drive, maintain of accessory reproductive glands and organs, maintain them, and initiate repair and growth of endometrium, because we just went over within menstrual cycle that your functional layer of the endometrium continuously break down during menstrual phase and continuously are remade during proliferative and maintained during secretory phase. So this is why every month your endometrium is undergoing breakdown, regrow, breakdown, regrow. So that's why you need those hormones there to initiate these processes and help with these processes. Now, the second hormone that's stimulated by the gonadotropin releasing hormone is that the pituitary gland will release luteinizing hormone. Okay, again, luteinizing is kind of a name, I would think, okay, because it coincides with corpus luteum formation. Okay, which when does corpus luteum form? And during ovarian cycle, it forms during luteal phase. Okay, so that's why luteal has to do with luteal phase of the ovarian cycle, where the corpus luteum is formed. Meiosis 1 is also completed with stimulation of LH, and you need that surge of hormone of LH, very, very fast increase in this hormone amount in order to stimulate ovulation. I'll talk about this when we get to the next slide on a summary chart of the two cycles. But an LH surge of hormone peak at a very high rate is needed for ovulation stimulation. Okay, and then it will cause, because corpus luteum is formed, which then stimulates secretion of progesterone, and we just said progesterone is very important for maintaining and sustaining your endometrium layer, the functional layer anyway, and that rise in progesterone will sort of acts as a negative feedback back on gonadotropin releasing hormone GnRH. Okay, so it's kind of similar to the male reproductive system, but just for different purposes. Okay, FSH is for follicular phase, for development of the follicle and secretion of estrogen. LH is for corpus luteum production, formation, and for ovulation itself, for the egg to come out, and also for secretion of progesterone once corpus luteum is formed. Okay. All right, so this is a very good summary chart for this chapter that covers ovarian cycle and your uterine cycle. So here's ovarian cycle right here, and here's uterine cycle. Okay, and what it's showing that it's all these time points, okay, coincides together, okay? Day 1 through 7 of menstrual cycle, day 1 through 7 of ovarian cycle, okay? Day 7 through 14, day 7 through 14 ovarian cycle. So it's kind of showing you sequentially what happens with these two cycles, okay? Now, this here is your follicular phase of the ovarian cycle. This here is the luteal phase of the ovarian cycle, okay, where you have formation of the corpus luteum, and ovulation happens around day 14, where you have that LH hormone surge. That's why it comes out just slightly before that day 14. Okay, and this is what those ovulation kits are detecting for when you test your urine every single day throughout that cycle. Is they're looking for that rapid increase in LH hormone, okay, to denote when ovulation is going to happen. The other thing females like to look for is that rise in body temperature after ovulation. So technically speaking, when your egg has been ovulated, your body temperature is maintained slightly higher than when your body is not preparing for fertilization and implantation, okay? Now, this illustrates here the uterine phase. Your menstrual phase shows you the breakdown of your endometrium layer from very thick to now very thin layer down here. Proliferative phase is when you start to build that layer back up. And secretory phase is when you're maintaining that thick lining of the functional layer of the endometrium. Okay? And you see these formation of these spiral arteries I was talking about that elongates and goes all the way throughout the thickness of the functional layer to supply these uterine glands, these tissues, and even if an embryo was to implant in there, that's where the oxygen and nutrients is going to come from, is from these spiral arteries. Okay. And now you can see how it aligns with the hormones, okay? Progesterone is actually at a peak after formation of corpus luteum, and it maintains throughout your whole entire secretory phase. So that's why throughout the entire secretory phase, okay, you see high levels of progesterone, okay, because we're relying on progesterone to maintain this thickness of the endometrial layer, okay? And then you have estrogen that peaks right before ovulation, okay? So estrogen and progesterone. And where you have high levels of inhibin, that's when then both progesterone and estrogen climbs back down. And once your progesterone hits a low point, this is what's going to trigger spasm of your uterine muscles, and your whole uterine cycle goes back to menstrual phase, where then spiral artery starts to constrict and fall apart, blood starts to pour out, and your muscles or myometrium layer will spasm and try to eject all that blood away from the body, and you can refresh again when it comes proliferative phase, getting ready for ovulation all over again. Okay, so this is a very good summary chart for the two cycles and how the hormones comes into play. Okay. All right, so this wraps up and concludes our chapter 28 of the reproductive system, and we will follow through with what happens during fertilization and the embryo's implantation and growth process in our final chapter of the semester. Okay, all right, I'll see you then.